Welcome to the deep dive. This is where we take the source material you share with us, maybe articles, research, could be your own notes, and we really plunge deep.
That's right. We're extracting the core knowledge, those insights you might miss, and, adding enough context and conversation to make it all stick.
Exactly. Our mission is simple.
Yeah.
Give you a real shortcut, not just to being informed, but to really getting the heart of complex topics.
And today, we're tackling something pretty substantial.
Yeah.
A real engineering marvel in the body, actually.
Oh, yeah.
The foot and the ankle. This system of bones, joints, muscles, nerves. It carries our weight. It powers our movement. It's incredible.
And the source material for this.
We're drawing from some pretty dense stuff here, specifically excerpts from a very detailed surgical text. Think chapter 41 of Bailey and Love's Short Practice of Surgery.
Okay, Bailey and Love, serious stuff. So based on that material you shared with us, our mission for this deep dive is, well, it's ambitious. We want to build a really comprehensive understanding of the foot and ankle. We're talking dissecting the anatomy, all the intricate bits, understanding the biomechanics, how it actually works when we move, like walking or running,
Yeah, the dynamics.
and exploring the common problems, what goes wrong across different age groups. And the goal isn't just, surface level. We're aiming for that professional depth, helping you master this info.
It's so vital to understand, isn't it? Not just for doctors or physios, but really for anyone curious about their body or maybe dealing with foot or ankle pain themselves.
Absolutely.
It's just incredibly complex, but so fundamental. So we're going to break down this dense source material piece by piece, pull out those key facts, those fascinating details, make it digestible.
Okay, let's do it. Let's unpack this. Like any complex system, we got to start with the basics, right? The building blocks, anatomy.
Precisely. And the source material kicks right off with the bony framework. The foot is, well, it's incredibly complex, made up of typically 26 main bones.
26? In just the foot? That's a lot.
It really is. And they're organized, logically, into three main groups.
Okay.
You got 7 tarsal bones. Those are the bigger ones in the back and the middle of the foot.
That's chunky ones.
Yeah. Then 5 metatarsals of the long bones leading out to the toes.
Okay.
And then 14 phalanges. Those are the bones that make up the toes themselves.
So 7 plus 5 plus 14, that's 26?
Usually. The source does mention a variant, though. Sometimes a little toe only has 2 phalanges instead of 3.
Oh, interesting. So some people have 25.
Exactly. Brings the count down to 13 phalanges, 25 total foot bones. And then, don't forget the little extras. There are 2 small, sort of pea-shaped sesamoid bones under the big toe, the hallux.
Grismoids, right.
And the source says there can be other variable accessory bones, too. Little extra bits that aren't always there.
Okay, so a whole lot of bones packed in there. How do they all connect and, move together? That brings us to the joints. Let's start at the top, the ankle joint itself.
Right, the ankle joint proper. The talocrural joint, that's where the tibia and fibula, the lower leg bones, meet the talus bone in the foot.
We usually just think of it as a hinge, right? Up and down.
We do. Dorsiflexion foot up, plantar flexion foot down. But the source gives a really crucial detail here. It's not actually a simple hinge. It's shaped more like, a truncated section of a cone.
A cone. Okay, that sounds more complicated. How does that affect the movement?
Well, because it's not a perfect cylinder, the movement isn't just a straight hinge. And this is where it gets really interesting biomechanically. The source explains that movement at the ankle is actually linked to rotation of the fibula.
Plus smaller leg bone, it rotates.
Yep, at the syndesmosis.
Syndesmosis. Remind me.
That's a strong fibrous joint that holds the tibia and fibula together just above the ankle. So when you dorsiflex, lift your foot up, the talus bone sort of spreads the ankle mortise slightly. Okay. And that causes the fibula to rotate externally relative to the tibia. Just a little bit. And when you plantar flex, point your foot down, the talus narrows in the joint and the fibula rotates internally. It's this subtle but really complex interplay. Yeah. Essential for understanding how the ankle works and, how it gets injured.
So the leg bones actually twist a bit when you move your ankle. That adds a whole new layer. So what keeps this structure stable then?
Good question. Stability comes from 2 main things, according to the source. First, just the fit. How well the talus bone sits snugly inside that socket formed by the tibia and fibula of the ankle mortise, that's congruence.
Okay, the bony fit.
Exactly. And second, the ligaments. The integrity of those key ligaments surrounding the joint. The source highlights the medial ligaments on the inside.
Deltoid ligament.
Part of it, yes.
Right.
The lateral ligaments on the outside, the ones usually injured in a sprain. And the inferior tibiofibular ligaments, holding the very bottom ends of the tibia and fibula together, damage those, and you get instability.
Makes sense. Okay, moving down from the ankle joint. We've got the subtalar joint and this triple joint complex. Can you break those down?
Absolutely. So the subtalar joint, or talocalcaneal joint, sits right below the ankle joint. It's between the talus, that ankle bone, and the calcaneus, which is your heel bone.
Okay.
And the source notes it's not just one surface. It's actually divided into 3 distinct facets or surfaces.
Yeah.
Anterior, middle, and posterior.
3 facets for one joint.
Yeah. And this joint is key for different movements than the ankle. Its main role, along with 2 other nearby joints.
Which are?
The talonavicular joint between the talus and the navicular bone, sort of on the top inside of the midfoot. And the calcaneal cuboid joint between the heel bone and the cuboid bone, more on the outside. These 3 together form what the source calls the triple joint complex.
Okay. A complex of 3 joints. What's their main job?
Their primary function is inversion and eversion, turning the sole of your foot inwards towards the other foot that's inversion.
Right.
And turning the sole outwards that's inversion.
So side-to-side tilting, basically.
Kind of, yeah, of the hindfoot and midfoot. And the source really emphasizes how codependent these 3 joints are. If you limit movement in one, it significantly affects the others.
They have to work as a team.
Exactly. And interestingly, if you have to surgically fuse this triple complex, say for arthritis, it can actually impact the range of motion you have left in the ankle joint above it.
Wow, okay. They're definitely linked. What about the joints connecting the midfoot to those long bones heading to the toes, the TMP joints?
So metatarsal joints, yes.
Yes.
The source specifically highlights the second TMT joint. Its position is a bit different. It's slightly recessed, kind of set back, compared to the first and third TMT joints next to it.
Set back. Why is that important?
Because that recessed position makes it act like a keystone.
Like a stone arch, the central stone.
Precisely that analogy. It's the keystone for the foot's transverse arch, the arch running across the foot near the base of the toes.
Yeah.
It locks everything together.
So if that gets disrupted?
Big problems. Disruption of that second TMT joint and its ligaments is a very significant injury. Historically, it's known as a Lisfranc's injury.
Ah, I've heard of that. Named after someone.
Yeah, Jacques Lisfranc. He was a surgeon in Napoleon's army, saw these injuries in cavalrymen whose feet got caught in the stirrups. A Lisfranc injury, or any disruption of this joint complex, directly leads to a loss of that transverse arch. The result, an acquired flat foot deformity.
That's a powerful example. Injury to one small spot changes the whole structure.
Okay, so we've got bones, we've got joints. What about the things that actually move them, the muscles?
Right, the power source. The muscles that move the foot and ankle are mostly located up in the lower leg, surprisingly. Not so much in the foot itself.
Okay.
And the source divides these lower leg muscles into 4 distinct compartments. They're separated by tough sheets of fascia. Understanding these compartments is really crucial clinically.
Why is that? Because if you get significant swelling inside one, say, from an injury or overuse, the pressure can build up dangerously. That's compartment syndrome. It can damage the muscles and nerves in there if not treated urgently.
Okay, serious stuff. So let's list these 4 compartments and what's inside.
First up, the superficial posterior compartment. That's the back of your calf, the bulky bit.
A calf muscle.
Yep. Contains the gastrocnemius, the 2-headed muscle you see, and the
Sure.
soleus, which lies underneath it. They're the main powerhouses for plantar flexion, pointing your foot down. There's also a small muscle called the plantaris in there.
Okay, what's next?
Deeper in the back, closer to the bone, is the deep posterior compartment. This holds some really important muscles. Tibialis, posterior key for supporting the arch and pulling the foot inwards, inversion.
Right?
Then the flexor digitorum longus, which bends the 4 smaller toes. And the flexor hallucis longus, or FHL, that one flexes the big toe.
FHL, got it. What about the side of the leg?
That's the lateral compartment. On the outside, contains the peroneus brevis and peroneus longus muscles. Their main job is eversion, turning the sole of the foot outwards.
The opposite of tibialis posterior.
Exactly, they balance each other. And finally, the anterior compartment on the front of the lower leg next to the shin bone.
Okay.
This has the tibialis anterior, the main muscle for lifting the foot up, dorsiflexion. Then the extensor hallucis longus, which extends the big toes straight. The extensor digitorum longus, extending the lesser toes. And a smaller one, the peroneus tertius, which helps with dorsiflexion and version.
Okay, so those are all in the leg, acting on the foot via long tendons. Are there muscles in the foot itself?
Yes, definitely, though fewer and often smaller. The source mentions there's actually only one muscle on the top surface, the dorsum of the foot.
Just one?
Yep. The extensor digitorum brevis. It helps the long extensor tendons extend the lesser toes.
Okay. And the sole, the plantar side.
The sole is much more complex muscularly. It's arranged in 4 distinct layers of muscles. Lots of small muscles controlling fine toe movements and supporting the arch.
4 layers.
Yeah. And the source specifically notes that the intricate arrangement and the path of the nerves and blood vessels through these 4 layers is a, quote, favorite examination topic.
Meaning it's tricky and important for anyone studying this stuff.
Exactly. Tells you it's complex and clinically relevant.
Good to know. Let's talk about another really critical structure on the sole, the plantar fascia.
Yes, the plantar fascia. It's not a muscle, but a thick, really tough band of fibrous tissue, connective tissue.
Where does it run?
It starts right at the bottom of the heel bone, the calcaneus, and then fans out across the sole, inserting into the bases of the proximal phalanges, the toe bones closest to the foot.
What does it do? It sounds like more than just padding.
Oh, it's absolutely critical for function, especially during walking and running. Its main role is in something called the windlass mechanism.
Windlass, like you said before, like winding a rope.
Precisely. Think of the plantar fascia as the cable on a ship's windlass, or winch, as your toes extend upwards during the push-off phase of gait.
Right before your foot leaves the ground.
Exactly. That movement pulls the plantar fascia taut, like winding the cable. And this tightening does 2 incredibly important things.
Okay.
First, it significantly lifts and accentuates the medial plantar arch, the main arch on the inside of your foot.
Yeah.
Second, it essentially turns the whole foot into a rigid lever arm.
So it makes the foot stiff for pushing off.
Yes. That mechanism is absolutely essential for providing the stiffness and stability needed for an efficient push-off. And it's vital for maintaining the arch's structural integrity when it's under load. It's not just passively holding the arch up, it's actively making it rigid when needed.
That's a fantastic mechanical analogy. Really clever design. Okay, last piece of anatomy. The nerves and blood vessels. The neurovascular supply.
Right. Blood gets to the foot primarily through 3 main arteries that branch off from the lower leg arteries. There's the anterior tibial artery, which becomes the dorsalis pedis artery you can often feel on top of the foot. Then the posterior tibial artery, which runs behind the inside ankle bone and branches in the sole, and the peroneal artery also supplying parts of the foot.
And the nerves. Control and sensation.
Yep. Several key nerves handle that. The source lists the posterior tibial nerve super important as it branches into the medial and lateral plantar nerves that supply most of the muscles and sensation in the sole.
Plantar nerves for the plantar side. Makes sense.
Then there's the saphenous nerve, providing sensation along the inside of the ankle and foot. The sural nerve, for sensation along the outside edge and heel. The superficial peroneal nerve, for sensation on most of the top of the foot. Except for that little web space between the big toe and the second toe. That specific spot, plus the motor control for the muscles on the top of the foot, like that extensor digitorum brevis we mentioned, comes from the deep peroneal nerve.
Wow. Very specific territories.
It is. And the source mentions figures illustrating this complex network, including branches like the medial calcaneal nerve supplying the heel pad. This whole network is vital, for sensing the ground, telling the muscles what to do, keeping the tissues healthy.
Okay, that gives us a really solid, detailed foundation in the anatomy. All the parts, how they connect. Now, let's shift gears and understand how this complex machine actually works when we move. Let's talk biomechanics, specifically the gait cycle.
Right. The source material breaks down the gait cycle.
Yeah.
That's the whole sequence of events from when one foot hits the ground until the same foot hits the ground again.
One full step cycle.
Exactly. And it's fundamentally divided into 2 main phases. The stance phase when the foot is on the ground, bearing weight, and the swing phase when the foot is off the ground, swinging forward for the next step.
How much time is spent in each phase, typically?
In normal walking, the stance phase is longer. It makes up about 60% of the total cycle time. Swing phase is the other 40%.
And stance phase isn't just one solid block of time, is it? It has subparts.
No, you're right. It's broken down further into key intervals, describing how the foot interacts with the ground and how the body moves over it. First, there's heel strike to foot flat.
Initial contact.
Right. Heel hits, then the rest of the foot lowers down. Second, the period from foot flat until your body's center of mass passes directly over your ankle. This is mid-stance, where the foot goes from absorbing shock to being a stable base.
Okay.
And third, the ankle joint plantar flexes you push down through the ball of your foot, leading into toe off. That's propulsion.
That describes walking pretty well. How does running change this whole cycle?
Running changes things significantly. Much higher speeds, much freer forces involved. One key difference the source highlights is the period of double limb support.
Meaning when both feet are on the ground?
Exactly. In walking, there's always a moment, up to maybe 12% of the cycle, according to the source, where both feet are grounded simultaneously.
But when you run?
That disappears completely. Instead, running introduces a float phase, a brief moment where neither foot is touching the ground. You're literally airborne between steps.
The flight phase.
Right. Also, obviously, the whole cycle time is much shorter in running. Things happen faster.
Faster cycles, air time, and I'm guessing much bigger forces hitting the foot.
That's the absolutely crucial point. The source emphasizes this. While the cycle is faster, the forces generated and absorbed by the foot and ankle during running are massively increased compared to walking. Exponentially higher loads.
And that explains a lot about running injuries, right?
It's a huge factor.
Yeah.
Understanding that increased load is key to understanding why certain injuries are so much more common or more severe in runners compared to walkers. The same structures are just dealing with vastly different demands.
Makes perfect sense. That biomechanical stress really sets the stage for things going wrong.
Exactly. Which leads us nicely into the next big section.
Right. So we've built the structure with anatomy. We've seen how it moves with biomechanics. Now let's spend the rest of our deep dive on the pathology, what goes wrong in the adult foot and ankle. The source material really digs into this, mentioning that, specific examination techniques and kids' conditions are covered elsewhere in the text.
Correct. So we're focusing on adult problems here.
Yeah.
And we'll start right at the forefoot, the really common area for issues.
And probably the most visible problem for many people is the bunion, right? Hallux valgus.
Hallux valgus, yes. That's the specific term for the deformity. The source defines it as a deviation of the big toe, the hallux, moving away from the body's midline towards the smaller toes.
So the big toe angles outwards.
Towards the other toes, yes. And this usually comes with what people call a bunion. That's the prominent bump you see on the inside edge of the foot, at the base of the big toe.
At that first metatarsal head joint.
Exactly. And that bunion bump isn't just bone. It's usually a mix of bone enlargement and inflammation of the bursa, the little fluid sac over the joint.
Who tends to get these?
They're extremely common, significantly more frequent in women than men, and often bilateral, affecting both feet. The source mentions a belief in an inherited tendency.
So it runs in families.
Often seems to, yeah. And it discusses the ongoing debate about whether wearing enclosed shoes, especially shoes with narrow toe boxes, actually causes them or just accelerates their development in people who are already predisposed. That's not fully settled.
Interesting. How does the deformity actually progress? And what are the symptoms besides just the bump?
Well, as the big toe drifts further sideways, the whole first ray, that's the first metatarsal bone and the big toe together, becomes less effective. It often elevates slightly and doesn't bear its share of the weight properly.
It gets defunctioned, as the source puts it.
Exactly. And because the first toe isn't doing its job, the load gets transferred sideways onto the second toe joint, the second MTP joint.
And that causes problems there.
Oh, yes. Overload leads to pain, swelling, sometimes damage to the plantar plate, that's the stabilizing ligament underneath the joint. It can even lead to instability or dislocation of the second toe. You'll often see a really prominent callus, hard skin, under the ball of the foot beneath that second joint because of the extra pressure. And sometimes the second toe itself starts to buckle and become a hammer toe.
Wow, it really does cause a cascade of issues across the forefoot. So how do you manage hallux valgus?
Well, non-operative treatment is always the first step. Basically, making room for the foot. Wearing shoes with a wider, deeper toe box to avoid pressure on the bump. Maybe using pads or orthotic inserts to relieve pressure points.
Accommodation, essentially.
Right. But if that's not enough to relieve the pain and functional issues, then surgery is often considered.
And how successful is surgery?
Surgery is offered frequently, but the source provides a really important dose of reality here. It mentions a reported 10% rate of significant patient dissatisfaction after bunion surgery.
10%, that's quite high.
It is. It means a notable number of people don't feel the surgery fully met their goals or solved their problems, even if technically successful, and maybe another 20% have milder dissatisfaction. So managing expectations is key.
Okay. What are the actual surgical options? It sounds like there isn't just one standard bunion operation.
You're absolutely right. The specific procedure depends heavily on how severe the deformity is, and maybe surgeon preference too. For mild cases, a distal osteotomy is common.
Osteotomy meaning cutting the bone.
Yes, cutting and realigning the bone. Distal means closer to the toe joint. A well-known example is the chevron osteotomy. It's a V-shaped cut in the metatarsal head.
Okay. What about moderate bunions?
For moderate deformities, surgeons might do osteotomies further back in the shaft of the metatarsal. The source mentions the scarf osteotomy, described as an elongated Z-shaped cut, or the Ludloff osteotomy. Carl Ludloff is mentioned historically here. Or they might do basal osteotomies, cutting the bone even further back near the midfoot. Things like a proximal chevron or a crescentic osteotomy.
And for really severe bunions?
You might need combinations of those shaft and basal osteotomies. Or a very effective procedure, especially if that first TMT joint back in the midfoot is unstable or hypermobile, is to fuse the first TMT joint itself.
Fusing a joint further back.
Yes. Often called a modified Lapidus procedure, named after Paul W. Lapidus. Alternatively, for severe cases or unstable joints, fusing the big toe joint itself, the first MTP joint is an option.
What are the implications of those bigger corrections, like basal osteotomies or fusions?
Well, they allow for massive correction of the angle. But the source warns they carry a higher risk of either elevating the first metatarsal too much or depressing it. Either way, it can shift weight bearing and potentially cause overload pain somewhere else. These bigger procedures are typically stabilized with plates and screws.
What about that older procedure, the Keller? Is that still done?
Keller's excision arthroplasty, named after William Lorden Keller. It's still an option, but the source suggests it's generally reserved for specific patients now. It involves removing the base of the first toe bone, the proximal third of the proximal phalanx.
Taking a piece of bone out of the toe itself.
Right. It effectively defunctions the big toe and the sesamoids, takes the pressure off, but weakens the toe significantly. So it's usually reserved for lower demand, perhaps older or higher risk patients where complex bone healing might be a concern.
Are there newer, maybe less invasive ways to do bunion surgery?
The source does mention minimally invasive techniques. Says they've been developing and are used widely, especially in Europe. However, it notes there are limited published long-term outcomes from the UK specifically, and they aren't really considered mainstream there yet. Still evolving.
Okay. Now, with any surgery, there are risks. What are the potential complications people should be aware of with bunion surgery?
The source lists several. Infection, obviously, at the surgical site. Damage to the small cutaneous nerves on the top or side of the foot, which can lead to numbness or sometimes painful neuromas.
Nerve issues.
Yes. Then there's recurrence, the bunion coming back over time. Or, less often, overcorrection of the toe pointing inwards too much. Stiffness in the big toe joint is common. And that transfer lesion, we talked about developing pain under the second toe because the first toe isn't working right after surgery.
And the dissatisfaction rates.
Right, worth remembering that 10% significant, 20% mild dissatisfaction. And sometimes early arthritis can develop in the operated joint, which might eventually need revision surgery, often converting it to a fusion.
So even a successful operation has potential downsides and limitations. Okay, let's shift to another common big toe problem, but quite different. Hallux rigidus.
Hallux rigidus, yes. Very different from the valgus deformity. This is all about stiffness and pain in the first MTP joint, the big toe knuckle. The defining feature is loss of dorsiflexion. You can't bend the toe upwards very well.
It gets rigid.
Exactly. And it's usually accompanied by significant osteophyte formation bone spurs, especially on the top, dorsal, and sides of the joint. The source mentions X-rays clearly show this characteristic look.
What causes this stiffness and pain? Why does it happen?
It can affect both adolescents and adults. In adults, it's often linked to a history of trauma. Maybe one significant injury, or more commonly, repetitive microtrauma. Think athletes, dancers.
Wear and tear.
Pretty much, yeah. There can also be a strong family history. And sometimes it could be the first presentation of something systemic like gout or other rheumatological conditions. But the main symptoms are that stiffness and pain, especially when pushing off the toe during walking.
How is hallux rigidus treated?
Well, non-operatively, the source says the most effective thing is footwear modification.
Shoes again.
Yep. Stiff-soled shoes are key because they reduce how much the toe needs to bend upwards when you walk. Shoes with a deep toe box also help accommodate those bone spurs on top, and rocker-soled shoes.
The ones with the curved sole.
Exactly. They're really good because they let you roll through the step without needing much toe extension at all. And the source notes these are widely available now, not just specialty shoes.
Okay. And if shoes aren't enough, surgically?
Surgical options exist. Injections into the joint, maybe cortisone to calm inflammation. Sometimes manipulation under anesthesia to try and break up stiffness, though that's less common. Procedures that tackle the bone spurs are frequent. Colectomy is one.
Colectomy.
It means surgically removing the bone spurs, particularly the ones on top that are blocking the upward movement. Basically, a radical debridement and excision of the blocking spurs to try and restore dorsiflexion.
Does that work well?
It can provide good relief, especially for pain caused by the spurs themselves bumping or limiting motion. For more severe pain and stiffness throughout the joint, fusion of the MTP joint is another mainstay.
Fusing the big toe joint solid.
Yes. Or interposition arthroplasty is an option. That involves removing the damaged cartilage surfaces and putting something else in the space, maybe tissue, maybe a spacer, kind of like a modified Keller procedure sometimes.
What about actually replacing the joint, like a hip or knee replacement, but for the big toe?
Prosthetic arthroplasty. Yes, implants exist. Hemiarthroplasty replaces just one side of the joint, total replaces both, or sometimes just spacers are used. However, the source is quite cautious here.
Oh, why is that?
It notes that historically, many early big toe joint replacements had high failure rates. Lots were actually withdrawn from the market. There's limited long-term data beyond maybe 9 years for most current designs.
So the jury is still out.
Somewhat. While the newer implants aim to preserve movement, the source says they haven't consistently shown better pain relief than fusion, and often come with high revision rates needing further surgery down the line. Some surgeons still offer them, trying to maintain mobility in the short to medium term, but it's a trade-off against those known risks.
So fusion is still a really major, reliable solution for severe hallux rigidus.
Yes. For severely painful joints, MTP joint fusion is highly effective at getting rid of the pain. That's its main advantage. The downside, obviously, is it permanently stiffens the joint, which changes foot biomechanics.
How does that affect?
The source mentions some patients can develop persistent pain under the sesamoid bones after fusion because the way weight goes through the forefoot changes. But despite the joint being fixed, most patients can actually still participate in sports after an MTP fusion.
That's surprising. Okay, let's talk specifically about those sesamoids again. The two little bones under the big toe joint. They can cause trouble on their own, right?
They absolutely can. A common acute injury involving them is turf toe.
Turf toe? Sounds like a sports injury.
It often is. Usually happens acutely from a forceful hyperextension, bending the big toe upwards, way too far too fast. Often happens on artificial turf, hence the name, but can occur on any surface.
What actually gets damaged in turf toe?
The source explains it involves disruption of the plantar plate, that ligament structure under the MTP joint, and you can also get fractures of the sesamoid bones themselves.
How's it treated?
Depends on the grade, the severity. Lower grade sprains are treated non-operatively. Rest, ice, maybe taping or a stiff-soled shoe. But higher grade injuries, especially if there's a significant tear or rupture of the plantar plate complex, often need surgical repair, particularly in athletes who need that push-off strength back.
Any specific tests mentioned?
Interestingly, the source mentions the Simmons test here, which is primarily for Achilles ruptures, squeezing the calf. It notes its non-reliability after a week for the Achilles and also mentions ultrasound looking for gap closure in turf toe, but adds there's debate about how important that finding is. So diagnosis is often clinical, plus imaging like X-ray or MRI.
What about chronic problems with the sesamoids, not just acute injuries?
Yeah, chronic pain is common too. This can include stress fractures of the sesamoids, a vascular necrosis or AVN where the bone tissue dies from lack of blood supply, or just general inflammation, often called sesamoiditis.
Are those all different things?
The source actually suggests they might all be related, maybe different stages or manifestations of the same underlying stress or vascular problem. Management usually starts with offloading, try to take pressure off the area with orthotics, maybe padding, sometimes a period in a boot. Injections are sometimes used.
Steroids.
Steroids can be injected, but the source warns they carry risk, potentially weakening tissue. Surgical options, like shaving down a prominent sesamoid or even removing one, are sometimes considered as the last resort. But the source warns these carry a high risk of persistent or even worse pain afterwards. They're tricky bones.
Definitely sounds like it. Okay, moving away from the big toe now, what about the lesser toes, 2 through 5? They get deformed too.
Oh, yes. Very common. Usually hammer toes, mallet toes, or claw toes.
Can you quickly define those again?
Sure. A hammer toe bends down at the middle joint, the PIP joint. A mallet toe bends down only at the end joint, near the nail, the DIP joint. And a claw toe bends up at the base joint, the MTP joint, and down at the middle in end joints, so it looks like a claw.
Got it. Are these deformities usually a sign of something bigger going on?
Often, no. They're very frequent and can just develop over time, maybe due to footwear or foot mechanics. However, and this is important, The source emphasizes they can be secondary to other foot problems, like a severe bunion pushing the second toe out of place, or, significantly, they can be an early sign of an underlying neurological disease.
So finding claw toes, for example, should prompt a closer look.
Definitely worth considering, especially if they develop progressively or seem out of proportion. Management starts non-operatively padding over any areas, rubbing on shoes, and wearing shoes with a deep, wide toe box to make room.
And if that doesn't work?
If the deformity is still flexible, meaning you can manually straighten the toe out, then soft tissue surgery can work well. Things like tendon releases or transfers, tendinotomies, or releasing the tight joint capsulotomy.
What if the toe is stuck in that bent position, a fixed deformity?
Then you usually need a bony procedure. The source mentions options like interposition arthroplasty, removing a bit of bone from the joint, fusion of one of the toe joints, making it permanently straight, or excision arthroplasty.
The source also mentioned isolated problems at the base of the lesser toes, the MTP joint extending or subluxing upwards.
Right. This often happens because the plantar plate under that specific lesser MTP joint has ruptured. It loses its support from underneath.
Can that be repaired?
Surgical techniques to repair these plantar plate tears have evolved. But the source notes the results are often only moderate. And interestingly, there seems to be a trend back towards non-operative management for some cases, perhaps because the surgery isn't always predictable. Ultrasound and MRI are good tools for diagnosing these specific tears.
Okay. Let's touch briefly on something called Freiberg's disease. What's that?
Freiberg's disease, named after Albert Henry Freiberg, affects one of the metatarsal heads, usually the second one. It's essentially an ischemic necrosis of the epiphysis.
Ischemic necrosis, meaning the bone tissue dies due to lack of blood flow.
Exactly, affecting the end part of the bone near the joint. This causes pain and swelling right at that MTP joint in the ball of the foot.
What's the typical outcome? Does it get better?
The source says it often settles down with just rest, especially when it occurs in adolescence. But in adults, if it leads to significant joint destruction and ongoing pain, management might involve surgery. Options include reshaping the bone with osteotomies, or sometimes excising part of the toe bone it connects to, the proximal phalanx base.
But there was a strong warning about this.
Yes, a very strong bolded warning in the source material. Excision of the whole metatarsal head should never be performed. Apparently, this leads to very poor outcomes and should be avoided.
Okay, critical point noted. Moving slightly back in the forefoot again, what about Morton's neuroma and the general term metatarsalgia?
Metatarsalgia is just a broad term for pain in the ball of the foot, under the metatarsal heads. The source notes it's usually secondary, meaning it's caused by something else. Could be problems with the MTP joints themselves, overload on certain areas, or irritation of a nerve.
And Morton's neuroma is one specific cause of that nerve irritation.
Exactly. Morton's neuroma, named after Thomas George Morton, is a specific painful condition caused by compression and thickening of one of the common digital nerves, the nerves that run between the metatarsal heads to supply sensation to the toes.
Where does it usually happen?
The source says the most common spot by far is the nerve between the third and fourth metatarsal heads. The next most common is between the second and third. And it's often secondary to other forefoot issues that might be crowding or compressing the nerve in that space.
How do you know for sure it's a neuroma?
Diagnosis is usually confirmed with imaging, ultrasound, or MRI are effective.
And the treatment?
First line is non-operative. Footwear advice, wider shoes again. Using an orthotic insert with a special pad called a premetatarsal dome or metatarsal pad. It sits just behind the ball of the foot and aims to spread the metatarsal heads apart slightly, taking pressure off the nerve.
Does that help?
It can, yeah. Steroid injections into the area are also commonly used to reduce inflammation around the nerve. The source mentions other things that have been reported, like cryotherapy, freezing the nerve, or alcohol injections, but says they're less common.
What if those don't work? Surgery?
Surgery is an option. It typically involves resecting or cutting out the thickened caneful nerve itself.
Removing the nerve, what's the consequence of that?
Permanent numbness in the toes supplied by that nerve branch. The source makes sure to point that out. It's a trade-off. Get rid of the pain but lose the feeling.
Are the surgical results always good?
Not always perfect. There are risks of ongoing pain, the neuroma recurring or a stump neuroma forming, and general patient dissatisfaction. The source mentions about 5% of patients have bad outcomes after resection. It also contrasts this with what it calls the European approach, which sometimes just involves cutting the ligament above the nerve, the intermetatarsal ligament, to decompress it, without actually removing the nerve. different philosophies.
Interesting. Okay, another common forefoot issue, especially in active people. Stress fractures.
Yes, stress fractures. Fatigue fractures from repetitive loading. Very common in athletes, dancers, military recruits. They usually show up in the forefoot, typically the metatarsal shafts.
What are the symptoms like?
The source notes the pain can be a bit vague, sometimes mimicking Morton's neuroma or just general metatarsalgia. If there isn't a clear reason for it, like a sudden increase in training, the source suggests a biomechanical or even biochemical evaluation might be needed to look for underlying factors, like poor bone density.
How are these forefoot stress fractures usually treated?
Metatarsal stress fractures in the forefoot are typically managed non-operatively. Rest from impact activities, maybe a stiff shoe or a walking boot for a while.
Yeah.
They usually heal well. However, and this is a really critical point the source makes, stress fractures can also happen in other crucial bones further back in the foot. Specifically mentioned are the navicular bone, a key bone in the midfoot arch, the talus, the main ankle bone, or the tibial sesamoid, one of those little bones under the big toe. And these often present initially with very vague, poorly localized pain.
So they can be harder to diagnose.
Much harder. And this is where the source puts a huge emphasis on urgency. Suspected stress fractures in the navicular, talus, or tibial sesamoid require prompt diagnosis and management.
Why the urgency?
Because these bones have a poorer blood supply in certain areas. And fractures here are much more prone to not healing, non-union, or progressing to a full break, which can have really serious long-term consequences for foot function.
So what's the recommended approach?
Early diagnosis, ideally with MRI, is key, and then immediate offloading, strict non-weight bearing, and protection, usually in a cast or boot. If imaging shows a full fracture line developing, the source says early surgical fixation might be needed, and potentially urgently.
So the takeaway is vague midfoot pain in an athlete or recruit.
Mandates urgent scanning and offloading. You cannot afford to miss these particular stress fractures. That's the clear message. The source also adds that follow-up might involve checking bone metabolism, bone density, or ruling out other things like myeloma if a stress fracture occurs without a clear cause.
Okay, really important clinical pearl there. Let's move back from the forefoot now and explore problems in the midfoot.
Right, the midfoot. That region includes the navicular, the cuboid, and the three cuneiform bones, plus all the joints connecting them.
And the most common issue here tends to be
arthritis. Midfoot arthritis is pretty frequent. The cause often isn't clear, might be primary osteoarthritis, just wear and tear. But risk factors include previous trauma, even microtrauma, rheumatological conditions, existing foot shapes like flat feet or high arches, cavus feet, maybe a missed Lisfranc injury from years ago, or Charcot neuroarthropathy.
What are the symptoms?
Typically pain, which can be quite vague and hard for patients to pinpoint exactly where it is. Stiffness is common. And sometimes you can actually feel bony lumps or spurs on the top of the foot dorsal osteophytes.
How is midfoot arthritis managed?
Non-operative is definitely the mainstay. Injections into the painful joints, orthotics to support the area, stiff-soled or rocker-bottom shoes, pain meds, activity modification. Surgery of the midfoot is considered high risk with only moderate outcomes generally.
High risk.
Yeah. And the source includes a particularly stark warning here. It states there is a universally poor outcome associated with attempts to fuse or do interposition arthroplasty on the lateral to tarsometatarsal joints, the joints connecting the fourth and fifth metatarsals to the cuboid.
Wow, universally poor. That's a strong statement against operating there.
It is. Suggests surgeons should be very hesitant to intervene surgically at those specific joints.
What about Charcot neuroarthropathy presenting in the midfoot? We touched on this, but specifically in this location.
Yes, the midfoot is a classic location for Charcot collapse. It often presents acutely. The foot suddenly becomes hot, red, and very swollen. It might be painful or surprisingly painless, depending on the degree of neuropathy.
And it's usually linked to?
Most often, secondary to diabetes, sometimes undiagnosed diabetes. But other causes of neuropathy can trigger it too. And because it looks so much like infection or gout,
it gets misdiagnosed.
Frequently.
Yeah.
Which delays the crucial treatment. The source again provides a strong stress on the urgency. Suspected acute Charcot requires immediate offloading, total non-weight bearing in a cast or specialized boot, and urgent management by a specialist team. It specifically refers to UK NICE guidelines for diabetic foot problems, hammering home that any unexplained acute swelling, heat, redness, ulcer, or new deformity in a diabetic foot is an emergency. Failing to act appropriately has serious medical and legal implications.
Truly a critical diagnosis not to miss. What about tendon issues in the midfoot?
Less common than hindfoot tendon problems, but the source mentions dorsal midfoot pain can sometimes be due to tendinosis degeneration of the tibialis anterior tendon, right where it inserts onto the bones on the top inside of the midfoot.
How's that treated?
Usually non-operatively. Rest, maybe physiotherapy. The source notes that injecting near this tendon carries a risk of rupture, but says this can be mitigated by putting the patient in a protective boot temporarily and giving DVT prophylaxis if they're immobilized.
And those fluid-filled lumps, ganglia, do they pop up in the midfoot?
Yes, midfoot ganglia are quite common. They're benign cysts, but they can cause pain, especially if they press on nerves running over the top of the foot, causing neuralgia. Sometimes they form over underlying bony bumps or arthritic joints.
Treatment.
First attempt is usually aspiration, drawing the fluid out with a needle, sometimes with a steroid injection. If it keeps coming back or is very bothersome, surgical excision is possible. But the source warns that recurrence after surgery is high, and a frequent complication is developing secondary nerve pain, neuralgia, after the surgery, maybe from scar tissue involving the nerve. So surgery isn't always a simple fix.
Okay. Let's move back further now to the hindfoot and the ankle joint itself. These areas are really prone to major issues like arthritis and significant tendon problems.
They are indeed. Let's start with ankle arthritis in that main talocrural joint. When non-operative measures fail, the definitive operative treatments are basically twofold.
Which are?
Total ankle replacement, TAR, or perhaps more commonly done historically and still very common, arthrodesis, which is surgical fusion of the joint.
Fusing the ankle solid versus replacing it, which is generally preferred now.
Well, fusion has been the gold standard for a long time, and it gives reliable pain relief for many. It used to be mainly done via an open incision. But arthroscopic techniques, keyhole surgery, are now widely available and often preferred by surgeons who do them.
Why preferred?
The source notes that arthroscopic fusion is associated with better outcomes overall, things like faster recovery, fewer complications like infection or wound healing problems. And it says arthroscopic fusion is considered mandatory if the patient has a pool soft tissue envelope, meaning thin or fragile skin, or if they have a clotting disorder where a big open incision would be much riskier.
Okay. What about ankle replacement? The appeal there is preserving movement, right?
Exactly. Total ankle replacement aims to maintain that up and down motion, which fusion obviously sacrifices. The implants themselves have evolved. The source notes historically, many were 3-component designs, but now 2-component designs are common, at least in the UKU market it refers to.
And how well do they work?
Outcomes seem really closely linked to how accurately the implant is positioned. Modern techniques using sophisticated instrumentation, even patient-specific guides or custom implants planned from CT scans are becoming mainstream to try and improve that accuracy and hopefully longevity.
So, TAR preserves movement. What are the downsides compared to fusion?
Well, the surgery itself often involves a larger incision than arthroscopic fusion, and the biggest issue is the risk of eventual failure. The implants don't last forever.
What are the failure rates like?
Reported revision rates needing more surgery because the implant failed or loosened vary a lot in studies. The source quotes figures from less than 1% up to maybe 7% per year. Many series show around a 3% failure rate annually requiring reoperation. But the source makes a really important point.
Which is?
That standard survivorship analysis, just looking at when implants are revised, might actually underreport the true number of patients who aren't doing well. Maybe they have pain or stiffness, but haven't had revision surgery yet. It mentions a recent paper confirming this underreporting. So the true success rate might be lower than some studies suggest.
That's a sobering thought.
It also speculates that regulatory hurdles in the UKU might be making it harder to develop and introduce new ankle replacement designs compared to the hip and knee replacement market.
So if you're comparing fusion versus replacement head-to-head for ankle arthritis?
Fusion has that long track record.
Yeah.
Good outcomes reported in over 90% of patients in many studies, especially arthroscopically, with minimal major complications. The downside is the loss of motion, obviously. And while the source says function is often described as virtually normal because other joints in the foot compensate,
There's
a but. That extra motion demanded of the adjacent joints, like the subtalar joint, can potentially lead to accelerated wear and tear and pain arthralgia in those joints down the line.
Okay. And TAR?
TAR preserves motion. That's the big plus. But it comes with the risk of implant failure, loosening, subsidence, and the definite need for future revision surgery in a significant number of patients eventually. It's a complex decision, weighing longevity versus mobility. The source also mentions an ongoing UK trial, the TARVA trial, directly comparing TAR versus fusion outcomes, but notes it's complicated by the fact that some leading implants have been withdrawn or had high failure rates recently.
So the evidence is still evolving. Now, let's think about arthritis in the joints below the ankle, that triple complex again. Subtalar, calcaneocabud, talonavicular.
Right. Arthritis commonly affects these hindfoot joints too. Treatment options here are perhaps more limited than for the ankle. If simple non-operative things like injections, orthotics, or shoe modifications don't work,
Then what?
then surgical fusion of the affected joint or joints is usually the recommended procedure.
Are there specific risks or warnings about hindfoot fusions?
Yes, a very strong warning reiterated in the source, similar to what was said about bunion surgery. Smokers and patients with diabetes have massively increased rates of non-union.
Where the bones just don't heal together.
Exactly, the fusion fails. This risk is so significant that it must be clearly discussed when consenting these patients for any foot fusion. The source also notes that painful tarsal coalitions, those abnormal congenital connections between hindfoot bones that can cause stiffness and pain, especially presenting later in life, often end up needing fusion if conservative measures fail.
What if a patient has arthritis in both the ankle joint and one or more of the hindfoot joints below it? That sounds really complicated.
It's a very complex scenario, yes. Surgically, you could do stage procedures, maybe fuse the hindfoot joints first, let that heal, then address the ankle later, or vice versa. Or you could try to do it all at once, but there's a major catch. The source highlights incredibly high non-union rates, potentially up to 75%, when you try to perform an ankle fusion in a patient who has already had a subtalar or triple fusion, or the other way around. Fusing across joints that are adjacent to already fused joints seems much harder to get to heal.
75% non-union, that's huge.
It's a massive risk. Because of this, the source notes some surgeons actually recommend doing a total ankle replacement instead of an ankle fusion if the patient has already had their subtalar or triple joint fused, trying to avoid that very high non-union risk of a second fusion.
That makes sense. Are there other options for combined ankle and hindfoot arthritis?
Yes, modern techniques include specialized hardware like third-generation hindfoot fusion nails. These are long rods inserted up through the heel bone that can cross and stabilize both the ankle joint and the subtalar joint simultaneously, aiming for fusion of both at the same time. These can be done via open or sometimes arthroscopic approaches.
And what about the most extensive fusion, a pantalar fusion? That sounds like fusing pretty much the whole back half of the foot.
It basically is. A pantalar fusion fuses the ankle joint plus the subtalar joint, and often the other main hindfoot joints like the talonavicular and calcaneocuboid, essentially locking up the entire hindfoot complex.
That sounds incredibly disabling.
It is quite disabling, yes. It eliminates motion across multiple critical joints, but the source says it's sometimes necessary for very severe cases.
Such as?
Patients with devastating widespread arthritis, like in severe rheumatoid arthritis. Gross deformities or stress fractures involving multiple joints. Cases where a previous ankle replacement has failed and the subtalar joint is now also involved. Widespread arthritis affecting all those joints, pantalar arthritis, or cases of a vascular necrosis where the talus bone collapses. It's a salvage procedure for end-stage problems.
You mentioned rheumatoid arthritis there. Let's talk specifically about how rheumatological conditions affect the foot.
They have a major impact. The foot is often one of the very first places rheumatological conditions, especially rheumatoid arthritis, show up.
What are the early signs?
Could be things like synovitis inflammation of the joint lining, particularly in the lesser MTP joints, those knuckles of the smaller toes, or just widespread inflammation in many small joints of the foot. Another common early feature is enthesopathy.
Enthesopathy.
Inflammation where tendons or ligaments attach to bone, so presenting as plantar fasciitis at the heel or Achilles tendinosis at the back of the heel.
And what are the classic deformities you see develop in a rheumatoid foot over time?
The source describes a very characteristic pattern, often severe hallux valgus bunion, frequently combined with hallux rigidus, stiffness in the big toe. You get marked subluxation or even complete dislocation of the lesser MTP joints. The toes drift upwards and sit right on top of the metatarsal heads, plus a significant arthritis and deformity developing in the midfoot and hindfoot as well.
What would you find on examination?
You'd likely see that obvious bunion, and you'd be able to feel those prominent lesser metatarsal heads sticking down into the sole of the foot, often dislocated upwards. They're usually very painful to press on.
How is the rheumatoid forefoot treated surgically? Are the principles different?
The principles often emphasize joint-sparing techniques if possible, trying to preserve the metatarsal heads while maybe shortening them and relocating the dislocated MTP joints. However, if the joints are completely destroyed by the disease, then partial excisions of the bases of the toe bones, proximal phalanges, are often performed. Fusion of the first MTP joint is almost always required in severe rheumatoid forefeet. And if deformity recurs later, excision arthroplasty might be needed.
The source mentions specifically excising the lesser metatarsal heads in RA.
Yes, sometimes the metatarsal heads themselves are resected. This can provide almost instantaneous dramatic pain relief from those dislocated prominent joints pressing on the sole. The source notes an interesting technical point. If a plantar approach is used making the incision on the sole, an ellipse of skin can be removed, which helps pull the fatty pad back underneath the remaining metatarsal ends, providing better cushioning.
But surgeons usually avoid scars on the sole, right?
They do, generally, because of pressure concerns. But the source suggests this is one situation where a plantar incision can give good results. However, it adds a crucial caution. Excising the metatarsal heads is a very definitive procedure. It leaves essentially no options for revision surgery later if problems develop.
Have the newer medications for rheumatoid arthritis changed how often these big forefoot surgeries are needed?
Yes, absolutely, dramatically so. The source explicitly states that the requirement for major rheumatoid forefoot correction procedures, like the classic Fowler's procedure, named after Alan W. Fowler.
What did that involve?
It was a combination of metatarsal head excisions and toe fusions, a big reconstructive surgery. But the need for procedures like that has fallen dramatically over the last couple of decades.
Why?
Because of the success of modern disease-modifying anti-rheumatic drugs, DRs. They control the underlying disease process much better for many patients, preventing the development of such severe destructive deformities in the first place.
That's great progress. What about rheumatoid disease in the midfoot and hindfoot?
In the midfoot, RA typically leads to pain and stiffness. Surgical options are limited, mainly injections or fusion if non-operative measures fail, as we discussed for general midfoot arthritis. The hindfoot and ankle are also very commonly affected in RA. Surgical fusions of the hindfoot joints are often required. For the ankle itself, the options are TAR or fusion. The source notes that TAR can have favorable outcomes in RA patients, maybe even better than fusion in some studies, but the results can be less predictable because RA patients often have more significant bone loss and deformity, making the surgery technically harder.
And are the soft tissues, tendons, ligaments also more vulnerable in RA?
Definitely. Patients with RA and other inflammatory arthropathies are more prone to enthesopathy, tendinitis, tendinosis, tendon degeneration, and even spontaneous tendon ruptures. And this leads to another crucial warning from the source, especially regarding injections.
What's the warning?
The Achilles tendon should never be injected with steroid in these patients, or arguably any patient, because the risk of causing a rupture is considered unacceptably high. Injecting steroids near other major tendons, like the tibialis anterior or tibialis posterior, is also considered similarly risky and should be avoided or done with extreme caution.
Okay, very important practical point. Let's broaden out now to talk about tendon disorders more generally in the foot and ankle.
Right. The source starts by noting that terms like tendinovitis, inflammation of the tendon sheath, and tendinitis, inflammation of the tendon itself, are often used loosely and may not be accurate histologically when you actually look at the tissue.
What do you usually see instead?
Often it's tendinosis, which is degeneration and microscopic tearing within the tendon substance, rather than active inflammation. These tendon problems are typically caused by injury, simple overuse, or as part of an underlying inflammatory disease like RA.
How are they usually managed?
The initial management is usually conservative. Rest, maybe anti-inflammatory medications. Even if it's tendinosis, they might help with pain. And crucially, physiotherapy to address any underlying biomechanical issues and strengthen the tendon appropriately. If there is true inflammatory tendinovitis, sometimes a tenosynovectomy, surgically cleaning out the inflamed sheath lining, might be needed.
Which tendons are most commonly affected by these kinds of problems?
The source highlights three main players: the Achilles tendon at the back of the heel, the tibialis posterior tendon on the inside of the ankle, the peroneal tendons, especially peroneus brevis, on the outside of the ankle.
Okay, let's focus on the Achilles first, particularly Achilles rupture. That sounds dramatic.
It often is. Achilles tendon rupture is relatively frequent. The classic patient profile is middle-aged, maybe 40s or 50s, the weekend warrior type returning to vigorous sport after being less active. but it can happen at any age, sometimes with very little force or provocation.
Is it always obvious when it happens?
You'd think so, but the source gives a startling statistic. Up to 1/4, 25% of acute Achilles ruptures are actually missed initially in primary care or the emergency department.
Wow, how can that happen?
Maybe the patient doesn't recall a specific pop, or the swelling masks the defect. Which is why the source emphasizes that the Simmons test, named after Franklin Aidan Simmons, is mandatory for diagnosis of a suspected acute rupture.
Remind us of the Simmons test.
You have the patient lie prone on their stomach with feet hanging off the edge, or kneel on a chair. You squeeze their calf muscle firmly. If the Achilles tendon is intact, the foot should passively plantar flex, point downwards. If the tendon is ruptured, the foot won't move, or moves very little. The source does add the caveat that this test becomes less reliable after about a week from the injury, as swelling and muscle spasm can interfere.
Okay, so if someone presents with acute calf heel pain after an injury, do the Simmons test. How are these ruptures managed once diagnosed?
Surgery. The trend, according to the source, is increasingly towards non-operative management for many acute ruptures nowadays.
Really? Even for a complete tear?
Yes. Often this decision is guided by ultrasound. If the ultrasound shows that the gap between the torn tendon ends closes nicely when the foot is pointed fully downwards in plantar flexion, many surgeons will opt for non-operative treatment. Though the source does mention there's still some debate about the true importance of that ultrasound finding.
What does non-operative treatment involve?
There are many protocols, but typically it involves immobilizing the foot in a cast or a special boot with the foot initially pointed downwards, plantar flexed, to bring the tendon ends together. Then, over several weeks, the angle is gradually brought up towards neutral as the tendon heals. This is combined with careful, progressive weight bearing and physiotherapy.
What about surgical repair? Still an option?
It's definitely still an alternative. Surgically opening the area and directly sewing the torn tendon ends back together. However, the source references large meta-analyses, big reviews of multiple studies, which have generally shown little or no significant advantage for surgical fixation compared to modern non-operative protocols in terms of final functional outcome, like strength or re-rupture rate.
But surgery has more risks.
Yes, surgery inherently carries a higher rate of complications, such as infection, wound healing problems, nerve injury, and adhesions. So the risk-benefit balance has shifted towards non-operative treatment for many patients.
Interesting. The source also mentioned a different idea about how these ruptures might happen, not always a sudden event.
Right. While the classic story is that sudden pop during sport, the source notes that many patients might actually be suffering a series of degenerative micro-tears in the tendon over time, which eventually culminates in a complete rupture, sometimes with minimal final trauma. It might not always be one single event causing it.
And it even mentions some people do okay with no treatment.
Yes. An interesting point mentioned is that studies in older adults have shown some can regain 70–90% of their normal calf power within a year after an Achilles rupture, even with no specific treatment, just letting it heal on its own. That might be functionally adequate for their needs.
What if a rupture is missed and diagnosed late, weeks or months later?
Then the options change. Non-operative treatment might involve using a specialized brace, like a sprung angle-foot orthotic, to assist with push-off. Operative treatment becomes reconstructive surgery. This isn't just sewing the ends together anymore, as they'll be scarred and retracted. It might involve bridging the gap with tendon grafts, transfer another tendon, like the FHL, the big toe flexor tendon, to help out, or using synthetic ligaments to augment the repair. Much bigger surgery.
Okay, what about chronic Achilles pain, not rupture, Achilles tendinosis?
Very common. The source divides it into two main types based on location. Non-insertional Achilles tendinosis would be pain, swelling, and degeneration in the main body of the tendon, usually a few centimeters above the heel bone insertion.
What causes that?
Usually overuse, common in runners. Management is typically non-operative load management. Physiotherapy focusing on eccentric exercises, addressing biomechanical factors. The source notes if someone has tendinosis in multiple tendons, it might suggest an underlying systemic inflammatory condition, like seronegative arthritis.
What treatments are used for non-insertional tendinosis?
Recent additions mentioned include shockwave therapy, which has shown some good evidence. Steroid injections into the tendon substance are strongly discouraged due to the high risk of causing a rupture. Other injections have been tried, high-volume saline injections, dry needling, sclerostin injections, but the source suggests these are used less now that shockwave therapy is more established. Surgery, Debriding the diseased tendon tissue is an option for resistant cases, but only has moderate success rates.
Okay. What's the other type? Insertional tendinosis.
Yes, insertional Achilles tendinosis is pain right at the back of the heel bone where the tendon attaches to the calcaneus. This is often associated with a bony prominence on the back of the heel called a Haglund's deformity, named after Patrick Haglund.
A pump-bump.
Kind of, yeah. Or can be associated with bone spurs or bony shells that form within the tendon substance itself at the insertion point. These are often visible on a side view x-ray.
How is insertional tendinosis treated?
Conservative treatment is tried first, similar to non-insertional. But the source states that if there are significant bony spurs within the tendon, these cases rarely improve significantly without surgery.
What does surgery involve?
Modern techniques mentioned include minimally invasive or mini-open excision of the Haglund's deformity, shaving off the bump, or sometimes detaching the tendon, removing the spurs and diseased tissue from the tendon and bone, debridement, and then reattaching the tendon securely back to the calcaneus, often using suture anchors. Sometimes reshaving osteotomy of the calcaneus itself is done. However, the source again cautions that surgical management for both types of Achilles tendinosis has relatively high failure and complication rates, not always straightforward.
Okay. You also mentioned the peroneal tendons on the outside of the ankle being commonly affected.
Yes, the peroneus brevis and longus. They can suffer from tendinosis, degeneration, tenosynovitis, inflammation, less common, or they can subluxate.
Subluxate, meaning slip out of place.
Exactly. Slip out of the grooves they normally run in behind the fibula bone. Sometimes peroneal problems are associated with bony overgrowth irritating them, where they pass under the inferior retinaculum, a band holding them down further towards the foot.
Is there anything specific that makes peroneal problems worse?
Yes. The source highlights the association with a varus heel alignment, where the heel bone is tilted inwards. This position puts extra strain on the peroneal tendons. If a patient has both peroneal tendon problems and a varus heel, the heel alignment must be addressed as part of the treatment, often with surgery like a calcaneal osteotomy, cutting and shifting the heel bone, or even fusion. Otherwise, the tendon problems will likely just come back.
And you need to figure out which came first.
Crucial point the source makes. You have to establish whether the varus heel caused the peroneal issue, or if weakness dysfunction of the peroneals allowed the heel to drift into varus. Because treating the wrong primary problem will lead to failure.
How does that peroneal tendon subluxation happen, where they slip out of the groove?
It can happen spontaneously, or more commonly after an ankle injury, like a bad sprain. It's often associated with anatomical factors, like having a naturally shallow groove behind the fibula for the tendons to sit in, or a tear of the superior peroneal retinaculum, the main ligament holding them in that groove.
Can patients feel it happening?
Often, yes. They might describe a painful snapping sensation on the outside of the ankle with certain movements, and might even be able to demonstrate the tendon visibly slipping over the bone. Surgical repair is usually required for symptomatic subluxation, often involving deepening the groove in the fibula and repairing the retinaculum.
And peroneal tendinosis or tendinitis, how's that managed?
Primarily non-operatively rest, physio, maybe bracing. As with other tendons, injections are occasionally used but carry a risk of rupture. Surgical debridement, cleaning out damaged tissue, or repair of splits, tears, or ruptures within the peroneal tendons is well described, but again, the source notes only moderate success rates. Tendon surgery is often challenging.
Let's move on to a major topic. Acquired flat foot in adults. The source rightly points out there's a huge range of what's considered a normal arch, right?
Absolutely. Many people have naturally low arches and function perfectly fine. Acquired flat foot specifically refers to a foot that used to have a more normal arch, but then progressively collapses during adulthood. It's a pathological process.
What causes the arch to collapse like that?
The source lists several distinct underlying causes. Dysfunction of the tibialis posterior tendinus says this is the most common cause. Arthritis, or previous injury in the tarsometatarsal (TMT) joints, like a missed Lisfranc injury leading to midfoot collapse. Charcot neuropathy, especially from diabetes, causing bony collapse. Inflammatory or degenerative arthritis in key hindfoot or midfoot joints like the subtalar, talonavicular, or naviculocuneiform joints. Rupture of the spring ligament, that's a crucial ligament supporting the talar head on the inside. Or sometimes a tarsal coalition, that abnormal connection between bones becoming symptomatic.
But the main culprits are?
The source highlights tibialis posterior tendon dysfunction, PTTD, and TMT osteoarthritis as the commonest pathological drivers of acquired flat foot.
How is it generally managed?
Symptomatic relief is the first goal. Often achieved non-operatively with things like Orthos' custom or good off-the-shelf insoles with arch support. Rest from aggravating activities. NSAs for pain. Surgery is described as a major undertaking, but often highly successful for relieving symptoms and correcting the deformity when conservative measures fail.
Can you elaborate on that tibialis posterior tendon dysfunction, since it's so common?
Sure. PTTD is a progressive condition. It typically affects overweight individuals, often women, maybe people who already had slightly flatter feet to begin with. The tibialis posterior tendon, which runs down the inside of the ankle and is a primary dynamic support for the arch, starts to degenerate, stretch, and weaken. It can eventually rupture.
What are the symptoms?
Initially, swelling and pain along the course of the tendon on the inside of the ankle and foot, often worse after exercise they're not used to. As it progresses, the arch visibly flattens, the heel starts to drift outwards into valgus, and the forefoot may splay outwards.
Is there a key diagnostic test?
Yes. The source highlights a key clinical test for significant advanced PTTD, the single-leg heel rise test. The patient tries to stand on the affected leg alone and lift their heel off the ground, going up onto their toes. If they cannot do this, or the heel doesn't invert, turn inwards as they rise, it indicates significant weakness or rupture of the tibialis posterior tendon. It's a sign of an advanced stage. And if PTTD is confirmed and symptomatic, what's the treatment? Surgical treatment is often required for moderate to severe stages. It's usually a combination of procedures tailored to the exact deformity. Common components include a medial displacement calcaneal osteotomy, cutting the heel bone and shifting it inwards to improve the biomechanics and support the arch. Transferring a healthy tendon, usually the flexor digitorum longus, FDL, which bends the lesser toes, or sometimes the flexor hallucis longus, FHL, bends the big toe, over to take over the job of the failed tibialis posterior. And often repairing or reconstructing the spring ligament if it's damaged.
What happens if it's not treated?
The source warns that failure to treat progressive PTTD can lead to spectacular deformity. A severely collapsed, rigid flat foot that is very difficult to manage and causes significant disability. It includes figures illustrating this.
Okay. What about a situation where someone develops a flat foot suddenly, acutely, after an injury?
That's a different scenario from the slow progression of PTTD. Acute traumatic flat foot can happen, especially in young athletes or military recruits, after a specific injury, maybe a twisting fall. On examination, they'll have this new onset flat foot. But crucially, their tibialis posterior tendon is still working. They can still do the single leg heel rise.
So what's injured then?
In these cases, the injury is typically an isolated tear of the spring ligament complex. And the source advises that early surgical repair of the spring ligament in these acute traumatic cases is important to prevent a secondary fixed deformity from developing later on.
Makes sense to fix it before it becomes permanent. Let's talk about ankle sprains. Incredibly common. But what about when the ankle stays unstable afterwards?
Right, most people sprain their ankle, do some physio, and recover well. But a significant number of individuals develop persistent, functionally significant instability after a sprain, usually because the lateral ligaments on the outside didn't heal properly or were severely torn.
How do you assess that instability?
Clinically, an unstable ankle often shows a marked anterior drawer sign. The examiner stabilizes the lower leg and can pull the heel and talus bone forward excessively from under the tibia, indicating the ligaments holding it back are lax or torn. Stress x-rays can also sometimes show abnormal tilting or shifting.
What's the treatment if physiotherapy doesn't resolve the instability?
If conservative treatment, mainly intensive physiotherapy focusing on proprioception and peroneal strengthening, fails, then surgical reconstruction of the ligaments may be needed. The source indicates that the favored techniques now are anatomical repairs, like the Brostrom procedure, named after L. Brostrom.
What does that involve?
It involves directly repairing and tightening the patient's own stretched or torn lateral ligaments, usually the ATFL and CFL. Sometimes this anatomical repair can be supplemented with synthetic tapes or internal braces to provide extra support and allow for earlier mobilization after surgery.
What about using other tendons to reconstruct the ligaments?
The source explicitly states that older techniques, which involve harvesting parts of the peroneal tendons to reconstruct the lateral ligaments, are now considered largely obsolete due to the success of these newer anatomical repair techniques and augmentation implants. The goal is to restore the normal anatomy as closely as possible. It also mentions that other things can cause feelings of instability besides ligament tears, like osteochondral lesions, syndesmosis issues, or peroneal tendon problems.
Okay, let's pick up on that. Osteochondral lesion of the talus, or OCD. What is that exactly?
An OCD lesion is damage involving both the articular cartilage surface and the underlying bone, typically on the dome of the talus bone within the ankle joint. They're often suspected in patients who have persistent, deep ankle pain, clicking, locking, or sometimes feelings of instability, especially after an injury that hasn't fully resolved.
How are they diagnosed?
They don't always show up well on plain x-rays, especially early on. Diagnosis usually requires more advanced imaging like MRI or sometimes CT scans to clearly see the cartilage and bone damage.
Can the damaged cartilage and bone be repaired? Like, can you regrow normal cartilage?
That's the million-dollar question in orthopedics. The source notes a key challenge. True repair of damaged articular cartilage, restoring it to its original hyaline cartilage form, is not yet reliably possible with current mainstream techniques.
What about all those experimental techniques you hear about? Cartilage grafting, cell cultures, stem cells?
Yes, many experimental techniques exist and are being researched, things like OATS, osteochondral autograft transfer, moving plugs of bone and cartilage from elsewhere, ACI, autologous chondrocyte implantation, growing the patient's own cartilage cells in a lab and reimplanting them, using scaffolds or stem cells. However, the source points to meta-analyses, big reviews of studies, which so far have generally not shown a statistically significant functional benefit from these complex and expensive techniques compared to simpler standard approaches, at least not consistently.
So what is the standard surgical approach for OCD lesions then?
The mainstay of treatment for symptomatic OCD lesions that haven't responded to rest is surgical debridement and microfracture, or microabrasion drilling.
What does that involve?
Debridement means cleaning out any loose fragments of cartilage or unstable cartilage flaps. Microfracture involves using a sharp pick to create small holes in the bone exposed at the base of the lesion. This causes bleeding from the underlying bone marrow, which brings in stem cells and growth factors, stimulating a healing response.
Does it form normal cartilage?
No, it typically forms fibrocartilage, a scar-like cartilage. It's better than bare bone, can provide pain relief, but it's not as durable or smooth as the original hyaline cartilage. The source also mentions that if a large detached fragment of bone and cartilage is seen very early after an acute injury, sometimes it can be surgically fixed back into place with pins or screws. And importantly, in children and adolescents, juvenile OCD, these lesions often have a very high rate of healing spontaneously with just rest and activity modification, so surgery is usually unnecessary for them initially.
Good to know. What if someone has persistent ankle pain after an injury, but imaging doesn't show a clear OCD or major ligament tear? What else could be causing it?
The source lists several possibilities for ongoing pain in that situation. It could be simple synovitis, this persistent inflammation of the joint lining after the sprain. It could be mechanical irritation, perhaps from the inferior part of the syndesmotic ligament impinging slightly into the joint. It could be a subtle impaction injury where the bones bruise each other. Or it could be an undiagnosed, very subtle fracture or a small OCD lesion that wasn't initially obvious.
How do you investigate that?
MRI is considered mandatory to look for these subtle causes. Although the source does note that MRI isn't always great at visualizing synovitis itself directly, but it can rule out other structural problems.
How is synovitis treated?
Management is often non-operative, initially rest, anti-inflammatories, maybe physiotherapy. A steroid injection directly into the ankle joint can be very effective at settling down synovitis. If symptoms persist despite these measures, then arthroscopic debridement, going in with a camera and instruments to clean out the inflamed synovial tissue, may be required.
Okay. Let's shift focus now to neurological foot conditions. This sounds like a whole different category. Starting with pes cavus, the high arched foot.
Yes, pes cavus is a significant finding, and the source makes a really important distinction. If the high arch is unilateral, affecting only one foot, it should be considered a major red flag.
Why red flag?
Because unilateral pes cavus strongly suggests an underlying upper motor neuron lesion, something affecting the central nervous system, like the brain or spinal cord. A thorough neurological examination and imaging of the spine are considered mandatory in these cases to look for things like spinal cord tumors or other lesions causing that asymmetry.
Wow. What if both feet have high arches? Bilateral pes cavus.
If it's bilateral, the source states that most cases are still associated with some underlying neurological condition, though perhaps a peripheral one rather than central.
And what's the most common cause?
The single most common cause of progressive bilateral pes cavus, according to the source, is Charcot-Marie tooth disease, CMT, named after the three neurologists who described it, Jean-Martin Charcot, Pierre-Marie, and Howard Henry Tooth.
CMT. What are the typical features of that?
Patients with CMT often have a characteristic picture. Progressive wasting of the small muscles in the feet and lower legs, which can give the calves a very thin, inverted champagne bottle appearance. They may also have similar wasting in the hands. Symptoms include aches and pains, clumsiness, and the development of those high-arched cavavarus feet, high arch plus the heel turning inwards. On examination, you might find early signs like lock of vibration sense in the feet. Diagnosis is confirmed with nerve conduction studies and genetic testing.
What's the actual muscle imbalance in CMT that causes that specific cavavarus foot shape?
This is where the source corrects a common historical misconception. For a long time, it was thought the deformity was caused by the peroneal muscles on the outside being too strong or overactive, pulling the foot up and out.
But that's not right.
No. The source clarifies that the key deforming force is actually the relative preservation of the tibialis posterior tendon. As other muscles around the foot and ankle weaken due to the neuropathy, the tibialis posterior remains relatively strong, and its unopposed pull is what cranks the foot into that severe high arch, cavus, and inward heel tilt, varus.
That's a really important clarification. How are these severe neurologically driven deformities corrected?
Surgical correction is very often necessary to achieve a plantigrade foot one that can sit flat on the ground for stable walking and to try and rebalance the muscle forces around the ankle.
What procedure is always needed?
According to the source, a procedure that is always required in correcting significant CMT-related cavavarus foot deformity is transferring the tibialis posterior tendon.
Moving that strong tendon somewhere else.
Exactly. Because it's the main deforming force, you have to detach it from its normal insertion and reroute it. Most commonly, it's transferred to the dorsolateral side of the foot, the top and outside, where it can then help pull the foot up and out, counteracting the foot drop and varus tendency caused by weakness in other muscles.
Is that tendon transfer enough on its own?
Rarely. The bony deformities are usually quite rigid by the time surgery is considered. So other procedures are typically needed alongside the tendon transfer. Common ones include a lateralizing calcaneal osteotomy, cutting the heel bone and shifting it outwards to correct the varus alignment. A dorsiflexion osteotomy of the first ray, cutting the first metatarsal bone and angling it upwards to bring the forefoot down and correct the high arch.
Now what about the toes? They often get clawed in these conditions too.
Yes. So procedures to correct clawing of the great toe, like the Jones procedure, named after Sir Robert Jones, or the lesser toes, like the Hibbs procedure, named after Russell A. Hibbs, are often performed at the same time. These usually involve transferring tendons to help pull the toes straight. It's often a complex combination of soft tissue and bony procedures.
So summarizing the key points on pes cavus from the source.
Always investigate neurologically. Around 80% of significant pes cavus cases are linked to an underlying neurological disease. The commonest cause of bilateral progressive cavus is CMT. And crucially, unilateral pes cavus strongly suggests a potentially serious spinal cord issue, like diastomatomyelia, a congenital split cord, or a tumor, requiring urgent investigation.
Very clear messages there. Okay, let's move on to discuss tumors that can occur in the foot. Are they common?
Compared to degenerative or traumatic issues, primary tumors in the foot are relatively uncommon, but they do occur. The source lists the most common benign, non-cancerous tumors found in the foot. Ganglia, those fluid-filled cysts we discussed earlier, technically tumor-like lesions, giant cell tumors of the tendon sheath, and angiomyomas, benign tumors arising from smooth muscle and blood vessels, often presenting as small, sometimes painful lumps, perhaps on the sole. These may require surgical excision if symptomatic.
What about more aggressive but still usually benign conditions?
The source mentions pigmented villonodular synovitis, or PVNS. This is described as a locally aggressive condition that affects the synovium, the lining of joints or tendon sheaths. It's often found in the ankle joint.
How is PVNS diagnosed and treated?
Diagnosis is usually via MRI, which has a characteristic appearance, or by looking at tissue obtained from a biopsy or surgery. Treatment has traditionally involved repeated arthroscopic procedures to remove as much of the abnormal tissue as possible, synovectomy, but recurrence is common. The source notes that medical therapy with drugs like imatinib is sometimes used, and that more recently, complete en-bloc resection, surgically removing the entire affected synovial lining in one piece, is becoming more mainstream as a potentially curative approach. Surveillance after treatment is mandatory because it can come back.
Okay. Now, what about the most common lump or tumor found in the foot, even if it's not truly cancerous?
That would almost certainly be the plantar fibroma, also known as Lederhose's disease, named after Georg Lederhose, who described it.
Plantar fibroma. What is it and how does it present?
It's a benign thickening or nodule that develops within the plantar fascia, that thick band on the sole of the foot. It presents as a firm, often painful lump, usually in the main arch of the sole, and it can slowly grow. The source notes it's linked to similar fibrous tissue conditions elsewhere in the body, specifically Dupuytren's contracture in the hand, causing fingers to curl, and Peyronie's disease, causing penile curvature. Bering, Guillaume Dupuytren, and François de la Peyronie are mentioned historically.
How are plantar fibromas treated?
This is another point where the source gives very strong advice. Surgery should generally be avoided.
Avoided. Why?
Because they have a very high recurrence rate after simple excision. And surgery on the sole of the foot can lead to painful scarring, nerve damage, and other complications that can be worse than the original fibroma. Diagnosis can be confirmed with ultrasound or MRI, which typically shows the characteristic nodules within the fascia, often multiple or multifocal, and helps rule out other, more sinister causes of lumps. Treatment focuses on managing symptoms, padding, orthotics, sometimes injections, but surgical excision is usually reserved for very specific problematic cases and done with caution.
So if someone finds a lump in their foot, especially if it's large or growing,
Any large, growing, or unusually painful lump, especially with night pain, requires a formal workup following established tumor investigation guidelines to rule out malignancy. That's standard practice.
absolutely. Let's turn to infection now, a very serious topic, particularly septic arthritis in the foot or ankle.
Septic arthritis, bacterial infection inside a joint, is thankfully rare in the foot and ankle joints of otherwise healthy individuals. However, the source notes it's much more common in patients with diabetes, and whenever it does occur, it constitutes a surgical emergency.
Surgical emergency? Why?
Because the bacteria and the resulting inflammation can rapidly destroy the joint cartilage, leading to permanent damage and long-term arthritis, even if the infection is eventually cleared. Prompt treatment is essential to save the joint.
How does infection get into the joint?
Most commonly, it occurs after surgery or an injection into the joint, but can also happen through hematogenous spread bacteria traveling through the bloodstream from an infection elsewhere in the body and seeding in the joint.
What's the treatment?
Immediate surgical drainage is required. This usually means washing out the joint thoroughly, either arthroscopically or through an open incision, to remove all the infected fluid and debris. This needs to be followed by appropriate high-dosage intravenous antibiotics. It's crucial to get samples of the joint fluid during the washout surgery before starting antibiotics if possible, so you can culture it and identify the specific bacteria causing the infection and its antibiotic sensitivities.
What bacteria are usually responsible?
The most common culprit is Staphylococcus aureus. The source also notes that MRSA methicillin-resistant Staph aureus is becoming increasingly common, which complicates antibiotic choice. And it reiterates that even with prompt treatment, rapid cartilage destruction, chondrolysis often occurs, frequently leading to secondary degenerative arthritis later on.
Are certain patients at higher risk?
Yes, patients who are immunocompromised for any reason, including those with poorly controlled diabetes, are at higher risk of opportunistic infections from less common organisms. And in these patients, failure to treat joint infections aggressively with surgical debridement can have devastating consequences, potentially leading to amputation to control the infection.
How is septic arthritis diagnosed early? It sounds like speed is critical.
It is, but early diagnosis can be tricky. Plain x-rays are usually normal in the early stages. Diagnosis relies heavily on high clinical suspicion, a patient presenting with a suddenly hot, red, swollen, and exquisitely painful joint, often with fever and inability to bear weight. Blood tests, like white cell count, CRP, ESR, will show signs of inflammation infection. If diagnosis is uncertain, more sophisticated imaging like MRI or bone scanning might be helpful. But often the decision for surgical washout is based on the clinical picture and analysis of fluid drawn from the joint aspiration.
The source also briefly mentions tuberculosis.
Yes, just notes that TB can affect the bones and joints of the foot, sometimes causing major bony destruction. It includes a figure illustrating this, but says it generally responds well to surgical debridement, combined with the appropriate long-term anti-tuberculous drug therapy.
Okay. Diabetes has come up repeatedly as a major risk factor. Let's focus specifically on the diabetic foot as a whole entity. Why does diabetes cause so many foot problems?
It's a combination of factors, really. The source highlights two main culprits, secondary to the diabetes itself: neuropathy and microvascular changes.
Nerve damage and blood vessel damage.
Exactly. Neuropathy leads to loss of sensation, so patients don't feel injuries, changes in motor control, leading to foot shape changes and abnormal pressure points, and autonomic dysfunction, affecting sweat production and skin health. The microvascular changes impair blood flow, especially to the small vessels in the skin and nerves, which hinders healing and the body's ability to fight infection. Together, these factors create a perfect storm.
Making patients much more prone to.
Significantly increased risk of infection and ulceration, open sores. And, because of the neuropathy, even trivial trauma, bumping their foot, wearing a slightly tight shoe, stepping on something small, can go unnoticed and lead to serious complications, including deep infections or even that catastrophic bony collapse we call Charcot neuroarthropathy.
The link between ulceration and amputation was strongly emphasized.
Critically so. Ulceration is the pathway to major morbidity and, tragically, is the preceding event for the vast majority of lower limb amputations in diabetic patients. The source states this very clearly.
So preventing and treating ulcers is paramount.
Absolutely. Any new ulcer needs urgent treatment. The goal is always to get the ulcer healed and then, crucially, keep that foot ulcer-free long-term through preventative care, proper footwear, regular checks, managing calluses, etc.
What are the guidelines for managing an acute diabetic foot ulcer?
The source points directly to the UK's NICE National Institute for Health and Care Excellence guidelines as defining the optimal management pathway. This typically involves urgent assessment, often requiring hospital admission. A multidisciplinary team approach is essential. Radiological and clinical assessment to determine depth and extent, check for underlying bone infection, osteomyelitis. Surgical debridement of the ulcer to remove non-viable tissue. Appropriate antibiotics if infection is present. And critically, formal offloading of the foot, taking all pressure off the ulcerated area, usually with a total contact cast, TCC, or a specific type of removable boot.
And the source summarizes this how?
By stating unequivocally, ulceration in a diabetic foot is a surgical emergency requiring immediate referral and management according to these established guidelines.
Okay. Let's revisit Charcot neuroarthropathy again, specifically in the context of diabetes.
Right. As we've touched on, Charcot is that neuropathic destruction and fragmentation of bones and joints. While often classically described as painless due to the neuropathy, the source makes the point that the majority of patients actually experience some degree of pain, especially in the acute phase.
And diabetes is the main cause.
In the Western world, yes, by far. Elsewhere, leprosy is still a major cause. But basically, any condition causing significant peripheral neuropathy can potentially lead to Charcot foot.
How does it typically present?
The acute phase often presents as a dramatically hot, swollen red foot or ankle, and because it mimics other conditions so closely.
Like infection, gout, DVT.
Exactly. It's very frequently misdiagnosed initially. This leads to delays in the crucial treatment, which is immediate immobilization and offloading, often resulting in more severe deformity and worse long-term outcomes.
How can you differentiate acute Charcot from infection, especially if the foot is red and hot?
It can be very difficult clinically. If there's no break in the skin, no ulcer, then infection originating from outside is less likely, making Charcot more probable. MRI can sometimes help distinguish the pattern of bone marrow edema and soft tissue changes between the two. Sometimes, if there's real diagnostic uncertainty and no open wound, a bone biopsy might be needed to definitively rule out infection.
How long does the Charcot process take?
It's a long haul. From the initial acute destructive phase, fragmentation collapse, through to the later stages of coalescence and eventual bone consolidation and remodeling can take many months, potentially up to 18 months or even longer.
And the main treatment goal throughout that time?
The fundamental principle, according to the source, is to maintain a foot-shaped foot, meaning using appropriate casting or bracing to support the collapsing bones and joints, preventing them from healing in a severely deformed position that would create bony prominences prone to future pressure ulceration.
So what's the specific management in the acute phase?
Strict immobilization and non-weight bearing, usually in a well-molded total contact cast, TCC, or sometimes a specialized Charcot retaining orthotic walker, CROW boot. This protects the fragile bone and allows the acute inflammation to settle.
Is surgery ever done for Charcot?
Yes, increasingly so. While conservative casting has been the traditional mainstay, there's a growing trend towards a more aggressive early surgical approach in certain situations, particularly if it seems inevitable that a significant bony prominence will form, leading to future ulceration. Surgically removing that prominence, exostectomy, can dramatically reduce the long-term risk of ulceration and amputation.
What about reconstructing the collapsed foot?
Early surgical reconstruction of the Charcot deformity itself is also becoming more mainstream, especially for unstable midfoot or hindfoot collapse. This is complex, high-risk surgery, often involving extensive fusion of multiple joints with robust internal fixation, like long plates and screws, or large intramedullary nails going up the leg. The goal is to restore a stable, plantigrade foot shape.
What happens if treatment fails, either non-operative or operative?
Failure, unfortunately, usually results in a severely deformed, unstable foot that is impossible to fit into standard footwear and is highly prone to recurrent ulceration over bony prominences. This often leads eventually to amputation.
So, to recap the key messages on the diabetic foot.
The source summarizes. Diabetic patients are highly prone to infection due to the triad of neuropathy, peripheral vascular disease, and impaired immune response. An acute Charcot foot is often misdiagnosed, but constitutes a surgical emergency requiring urgent specialist management, offloading. And similarly, any diabetic foot ulcer is also a surgical emergency requiring urgent referral and management along established guidelines. These are non-negotiable points for clinicians.
Understood. Let's touch on one more category, nerves getting trapped or compressed entrapment neuropathies.
Yes. Besides the systemic neuropathies like in diabetes or CMT, individual nerves supplying the foot can get pinched or compressed at specific anatomical locations, causing pain, numbness, tingling, or burning.
And the treatment.
If conservative measures fail, treatment often involves surgical decompression, releasing the structure that's trapping the nerve.
Any specific examples mentioned?
Tarsal tunnel syndrome is the classic example given. This is where the posterior tibial nerve gets compressed in the tarsal tunnel, a space behind the medial malleolus, the inside ankle bone, as it passes into the foot. However, the source notes that true tarsal tunnel syndrome is actually much rarer than its counterpart in the wrist, carpal tunnel syndrome.
How is it confirmed?
Diagnosis often relies on clinical symptoms correlating with the nerve's distribution. Maybe a positive Tinel sign, tapping over the nerve reproduces symptoms, and confirmation with nerve conduction studies. But the source adds a cautionary note here too.
Which is?
That a high proportion of patients who undergo surgical release for tarsal tunnel syndrome continue to experience neurological symptoms and pain afterwards. The outcomes aren't always as predictable or successful as for carpal tunnel release.
Okay. Finally, let's address one of the most common complaints that brings people to see a doctor or physio about their foot. Heel pain.
Yes, heel pain is incredibly common, and the source states clearly that the commonest cause by far is plantar fasciitis.
Plantar fasciitis. We talked about the plantar fascia earlier. What are the symptoms when it gets inflamed or degenerated?
The classic symptom is pain located right under the heel, often slightly towards the inside, inferior medially. The hallmark timing is pain that is worst with the very first steps taken in the morning or after any period of rest, like getting up after sitting for a while.
That's startup pain.
Exactly. It often improves a little bit once the person gets moving, but then can worsen again later in the day with prolonged standing or walking.
What's the usual prognosis for plantar fasciitis? Does it get better?
The good news, according to the source, is that the vast majority of cases, maybe 90% or more, will settle down and resolve within about 18 months, often with relatively simple treatments. Surgery is rarely required and, importantly, often not successful when it is tried for chronic cases.
So what are the mainstay treatments, especially for cases that aren't resolving quickly?
Beyond the basics like stretching, calf and plantar fascia stretches, appropriate footwear, maybe night splints, the source highlights two mainstays for more persistent cases. Ultrasound-guided steroid injection into the most tender spot near the fascia's origin on the heel bone, or shockwave therapy, extracorporeal shockwave therapy, ESWT. Both have evidence supporting their use.
Is plantar fasciitis the only cause of heel pain?
No, definitely not. It's the most common. But the source lists several important conditions to consider in the differential diagnosis, things that could mimic plantar fasciitis. A stress fracture of the calcaneus, the heel bone itself, tarsal tunnel syndrome if nerve compression is causing referred pain to the heel, referred pain from the lower back, lumbar radiculopathy, inflammatory conditions like seronegative arthropathies, which can cause enthesitis at the heel, or even Lederhose's disease, those plantar fibromas, if a nodule happens to be located near the heel. So accurate diagnosis is important.
We have certainly covered an incredible amount of territory here, a really deep dive into the foot and ankle, hitting it from, well, pretty much every angle.
It really shows just how complex this system is, doesn't it? And the level of detail in that source material you provided was immense. We've gone through the intricate anatomy piece by piece.
Bones, joints, muscles, fascia, nerve.
Explored the crucial biomechanics, how it all works together to let us move. And then surveyed that huge array of conditions that can go wrong, from the everyday things like bunions and heel pain, right through to those really complex, potentially devastating issues like Charcot foot or the neurological diseases like CMT.
And what really strikes me is the interconnectedness, how a problem in one specific spot like that Lisfranc joint messing up the arch or the tibialis posterior tendon failing and causing the foot to flatten can just cascade and create problems throughout the whole structure.
Exactly. It underscores that the foot isn't just a random collection of parts. It's a highly integrated functional unit. And a disruption anywhere can have widespread effects.
So for you, our listener, really mastering this information, getting to grips with these concepts at this professional level, it provides just incredible insight, doesn't it?
It really does. Whether it's for understanding your own health better, maybe preparing for a discussion with your doctor, or just satisfying that deep curiosity about how our amazing bodies work. We've hopefully illuminated the diagnostic process, thinking about specific tests like Simmons, understanding when MRI or ultrasound is crucial, recognizing red flags like unilateral pes cavus or the signs of acute Charcot.
And the treatment principles, too. When to stick with conservative care, the specifics of different surgical procedures, the calectomies, osteotomies, fusions, replacements, and importantly, being realistic about their expected outcome, their limitations, and their inherent risks.
It really does make you pause and just appreciate what our feet go through every single day, the forces they handle. Maybe a final thought to leave you with.
Yeah.
Ponder the sheer resilience required. Think about the forces multiple times your body weight hitting that small structure with every jump, every run. And yet, even with all our advanced surgical techniques, we still face significant challenges in achieving perfect lasting solutions for so many conditions.
Like the failure rates for some implants.
Right, or the difficulty in reliably healing certain tendon problems, or the immense challenge of managing a Charcot foot effectively, or the ongoing need for research like that TARVA trial comparing ankle fusion and replacement.
It highlights that the journey to fully understanding and optimally treating the foot and ankle is definitely ongoing.
It really is. It requires constantly revisiting this kind of detailed foundational knowledge to truly appreciate that delicate balance between structure, function, and pathology. And perhaps just thinking about the absolutely vital role our feet play in our independence, our mobility, our quality of life every single day.
A lot to think about indeed. Well, that has been our deep dive into the foot and ankle, drawing directly from that detailed surgical text source material you shared with us.
It's been a fascinating exploration. Thank you for joining us.
We'll see you on the next deep dive.